Webinar series. I'm going to get started in the interest of time because we historically have had some great conversations at the end. So I want to leave plenty of time to talk and for everybody to ask questions. Thank you again for being here. This is our, I think, third of this year. And so we've had some really dynamic and interesting speakers all along the topic of childhood cancer and the environment. And so today we really have the honor of having Dr. Michael Scheurer with us here today. And he's going to be talking about evaluating the impacts of environment on pediatric cancer risk and survivorship. So I have the honor to introduce him. He is a professor of pediatrics at Emory University School of Medicine, and co-director of the Research and Epidemiology for Adolescent and Childhood Health, or REACH Center, and an epidemiologist with the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta. And his research focuses on identifying environmental and genetic risk factors for pediatric cancer, including childhood brain tumors, and treatment-related and long-term conditions associated with cancer survivorship. He's currently the president of the American Society of Preventive Oncology and the immediate past president of the immediate past U.S. co-president of the Brain Tumor Epidemiology Consortium. So thank you again so much for being here. I'm going to stop sharing and pass it along to you.
Great. Thanks again, Hannah, for the invitation and for the introduction here. I'm really excited to be with you all today. I really do hope this is the beginning of some conversations with many of the folks on this webinar, and maybe even for those who couldn't make it today. Um, in doing a little bit increasingly more of my research is really trying to focus on, linking back into environmental exposures and not only how they can lead to the development of cancer to begin with, but how they really might also contribute to some of the bad outcomes that so many of the children who are diagnosed with cancer have as they go through their therapy and also move from, being active on therapy and into survivorship. So I hope to spend a little bit of time with you today and really try to understand, mostly what we don't know yet about how these exposures can influence health in children and cancer survivors. So, don't have any financial relationships to disclose. And these are sort of the outline of a few of the things that we're going to talk about today. Why are we interested in environmental risk factors for pediatric cancers? I probably don't have to spend too much time, and I won't spend a lot of time on that today with this particular group. I do want to briefly review sort of the IARC nomenclature and what we quote unquote know about some of the known carcinogens. And you'll see why I want to point that out. And then I'm going to spend a few slides talking about some of my own opinions about the challenges, as well as some of the opportunities that we have for doing research in this area. And throughout, we'll talk about several examples of work that we've been doing over the last few years, as well as some ways that I think we can really expand research in this area moving forward. So, as many of you know, childhood cancer has increased by about 45% all told since the 1970s. And that equates to about a 0.7 to 0.8 annual percent increase in pediatric cancer diagnoses year after year. We do know that only about 10, maybe a little bit more, 10 to 12-ish% of these cancers are due to a known inherited pathogenic genetic variant. But there's growing concern over the contributions of environmental exposures, especially since that 10-ish, 10 to 12% doesn't really account for the overall increase in the number of cases that we're seeing. And while we do know that there are a small percentage of these cases that are due to exposure primarily to ionizing radiation and maybe a couple of other environmental exposures, we still don't fully understand, what's going on in terms of environmental exposures and pediatric cancers. So, as many of you probably also know, the International Association for Research on Cancer, or IARC, does their monograph series where they review all of the existing information about carcinogenic hazards to humans and place them into these four groups. And you can see the overall number of agents that have been reviewed are quite large, but the ones that we know are carcinogenic is really a small subset of those. So those group one agents is really what I want us to talk about a little bit more in depth over the next few slides. But the group twos are the probable impossibles, and there are a large number of those. Just means that there's some evidence to suggest that they may be carcinogenic to humans, but it's not definitive, or there's not consistent evidence. And the group threes are the ones, the largest group there, not classifiable as to its carcinogenicity. So we really don't know much about those at all. So, among the group one environmental toxicants, as they've been put out, they tend to group into these different categories. And this is my own grouping of these. We did a review of these recently. So, ionizing radiation comes in a few different forms: environmental metals, organic chemicals, compounds, and substances, herbicides and pesticides specifically as a group, and really importantly for pediatric cancer, parental occupational hazard exposures and what those mean for childhood cancer development, and then finally food and plant-based compounds. So the one thing I want to point out is kind of how I've organized these slides, and I want you to look at the growing number of these that are red that say no studies to date, especially in the pediatric cancer column. Because one thing that you'll see is that the majority of the evidence that we have linking environmental exposures primarily to cancer formation is going to be in adult cancer populations. There are far fewer of these studies in the pediatric column. So again, I mentioned before, we do know that several forms of ionizing radiation are associated with the development of certain types of tumors. Leukemia being the primary one that's been looked at, especially on the pediatric cancer side, but we also know that exposure to ionizing radiation can increase risk for CNS tumors and to a certain extent some other solid tumors. And you can see that this is probably the one where we have the most consistent evidence. As we move forward, though, through these other groups, the evidence isn't quite as substantial. So, for the environmental metals, no studies to date have been conducted for beryllium. There were a couple of studies for arsenic that showed no association in the pediatric column. But for cadmium, chromium, and nickel, we do see increased risk, and there is consistent evidence that they do increase the risk for certain pediatric cancers. And we also know that there are some organic chemicals or compounds that are associated, again, primarily with leukemia. And I think you'll see over and over again that more of the evidence in the pediatric column is in the leukemias, and that's because that's the most common form of cancer in children, and we have numbers able to be able to look at these in epidemiologic studies. But none of these are really surprising to the people on this call, I'm sure, but benzene, benzopyrene, 1,3-butadiene, PCBs, tobacco smoke, again, primarily associated with leukemia in children, but benzopyrene's also been shown to be associated with neuroblastoma. Then we start moving through all of the others, right? So there's hints at adult cancers, a few adult cancers that have been associated with some of these, but no studies to date have formally and consistently evaluated these particular exposures for pediatric cancers. And yet another page of the organic chemicals and compounds where we don't have enough evidence to really look at this in the pediatric context. Now, the one exception here is the last one. So they just completed the monograph on diesel and engine exhaust. And for lung cancer, I think was the only adult cancer shown to have consistent evidence for exposure to diesel exhaust. But there was no consistent evidence for the pediatric cancers that were reviewed. And again, I looked at the monograph again this morning. Really, the only one that was looked at was primarily leukemias. And again, the evidence was inconsistent across the few pediatric leukemia studies that were included in the monograph. For herbicides and pesticides, PCP has been shown to be associated with pediatric leukemia and lymphoma, lindane, and some others. Really, not enough studies to date to really be able to look at them. Occupational hazards, again, for our leukemia patients and CNS tumor has been reported to be associated with parental painting and parental exposure to wood and leather dusts. No real association for the studies in associating with welding fumes, but no studies to date reported on some of these other occupational hazards. And we've got yet a second page of those where we really don't fully understand the risk for pediatric cancer formation if their parents are involved in some of these other occupations. And then finally, within the food and plant-based compounds, we've known for a long time that in nitrosamines, especially consumed during pregnancy, increase the risk for CNS tumors in the offspring. And there have been a number of studies over time looking at the effects of alcohol use, especially during pregnancy or even pre-pregnancy or preconception, on the risk of pediatric cancers in offspring. And there have been suggestions of increase for leukemia, CNS tumors, and neuroblastoma. But again, for the other food and plant-based compounds that we know are associated with adult cancers, we really don't know if they're associated with pediatric tumors or not. So, as I see it, and these are the, in my opinion, slides that I mentioned earlier, there are a few challenges that we have in relation to fully understanding the association between environmental exposures and pediatric cancers. The first one, I think, is that it's difficult to estimate the exposure during critical periods of development. So we've got three primary windows of exposure that we typically consider for environmental agents as they relate to the development of pediatric cancers: the preconception period, the in utero or fetal development period, as well as early childhood. But it's often difficult, especially for preconception or in utero, or it has been to date, difficult to measure these exposures. And even more so, even if we think during early childhood, there aren't a lot of cohort studies where repeated biosampling has been done so that you can measure these exposures pre-cancer diagnosis. So that's the first challenge that we have. The second one, as I see it, again, we just went over this, but many of the associations that we see among environmental exposures and risk of cancer have been done in adult populations, and they haven't been really fully evaluated for the risk of cancer for children and adolescents. Investigations to date really have relied on self-reported questionnaire data and/or residential assignment of area-based measures for our environmental exposures, which don't always give us the best data. And again, we could have many discussions on the pros and cons of doing those things. Many times we hope that they're as a first step moving us forward. And then finally, the last challenge I see is that pediatric cancers obviously are less frequent than adult cancers. Therefore, they require large, often multi-institutional or multinational studies to really get the sample sizes that we need to be able to evaluate these exposures in the first place. Now, that being said, I feel like we also have several opportunities in this area. And the first one is to utilize novel analytic tools, both for biomarkers of exposure, but also for analytic or novel matrices. I think that's my next bullet point, actually. But analyzing, using novel tools for a development of biomarkers of exposure that can help us also pinpoint timing of the exposure. We can also look at evaluating the role of exposures among vulnerable populations. So a lot of the knowledge that we have, especially around ionizing radiation and some other chemical exposures, have come from unfortunate accidents like Chernobyl or things that happened after nuclear bomb exposures that guided some of our knowledge around these things. We can also evaluate, and I think we should be evaluating, the interaction of environmental exposures with genetic variation. And I had several conversations with my adult cancer epi colleagues who say, we don't really look at GE interactions anymore on the adult side. We don't think they're all that useful or important. But I think for pediatric cancers, I think there's still opportunities to look at these interactions, and we really should be looking at them. And then one of the final opportunities, and one of the shifts that I've made in my own research is really, I think we have the opportunity to evaluate the effects of environmental exposures on treatment-related outcomes, survival, and health effects that happen, later in life among our adult survivors of pediatric cancers. So my own personal research, I'm not just focused on the etiology, but I'm also looking at what's happening to kids while they're on treatment, and then what happens to them as they age into adolescence, early adulthood, and eventually older adulthood, and what that means for chronic health conditions in those groups. So, okay, let's talk about a few things that we've been doing or that I see as some further opportunities for each one of these. So the first thing I mentioned is sort of overcoming measuring exposures, or the limitations that we have in measuring exposures, especially those that are happening in early life, by using some of the novel omic technologies that have come out lately. So one of the first things that people have been doing, we know that there are certain exposures that can lead to epigenetic modifications. Smoking is a good example. We know what the epigenetic marks or the methylation marks that happen as a result of smoking exposure. And some of these marks are transgenerational. So we can see what happens in mom and dad is then carried forward for their offspring, and then those could be carried forward into further offspring. And there's even evidence that early life stress exposures and things like that are also transgenerational. So I think there are some real opportunities in terms of looking at some of these epigenetic markers of exposures that we may not always have the ability to have measured directly. So that's the first one. The second one is using untargeted or even targeted metabolomics as a way to measure exposomes. So we've started to do some of this work, especially using metabolomics in this regard. And what I really think one of the benefits of the metabolomics is that it provides sort of a snapshot of what's going on in the system at the time that you make the measure. And we're able to do metabolomic measurements on increasingly smaller amounts of starting material. And I'll come back to that point in just a few slides. And then the final way I think we can overcome some of this measurement that we couldn't do previously is using somatic mutational signatures within the tumors themselves. And a lot of this work has already been done, especially on the adult side, but we're starting to see more and more of this from the pediatric side as well. And I want to just remind people who maybe haven't seen this in a while or who haven't been exposed to this yet, but there are currently 30 signatures that have been validated as being mutational signatures. And you can see the number of and the variety of the cancers that have been associated with these particular exposures. Um, Now, what I've highlighted here, or tried to circle in red, are the more pediatric oriented cancers that we're interested in here. And several of these signatures, we know what caused those signatures. So, for instance, signature 2 and signature 13 are thought to be downstream effects of APOBEC activity. And several of these are also associated with defective DNA mismatch repair processes. Signature 7 is the UV signature. So exposure to UV is the one that caused that specific mutational signature in those tumors. What you can see is that for the pediatric tumors, there are a few of these that we can recognize, but there are far fewer of them than have been recognized for a lot of the other more adult-oriented cancers. So I think there's still a lot of work that can be done here, but having access to the tumor and being able to sequence those tumors provides an additional layer of input about some somatic mutational signatures that might have driven that tumor to develop. Now, there are a lot of others like signature 5 here, which appears across the board that we really don't know what's driving that. So one of the benefits I think that we have in terms of, building large molecular epi childhood cancer cohorts is that if we have the tumors and we have some measure of environmental exposures that these individuals may have gone through, we may be able to help identify a lot of these quote unquote unknown etiology signatures because we'll have some measure of environmental exposure that we can then attach to these signatures and hopefully try to tease apart a little bit more readily some of the like I said, quote unquote unknown signatures. Okay, so the next way that I think we have some opportunities is overcoming, how we can measure these. So many of you probably know Dr. Manish Arora from the Icahn School of Medicine at Mount Sinai. We've been working with him, as I'm sure several of the other people on the call have been as well, to use primary deciduous baby teeth as a matrix for measuring environmental exposures. So primary teeth actually start developing in utero and they grow incrementally, creating sort of these visible growth rings, much like, as a tree grows, you have growth rings around the tree. The tooth sort of forms that way as well. And his lab has really developed some really cool technological methods to measure early life uptake of organic and inorganic compounds. And we've focused most of the work that we've been doing on metals. And one of the really cool things is we've had a really strong reaction from our study participants over the teeth analyses. And I just show you here one note that a parent shared with us that one of their kids who was involved in the study wrote to the tooth fairy. It said, "Dear Tooth Fairy, I pulled out my own front tooth on this date. I'm so excited, but can you please leave it behind so we can give it to the doctors to do studies on it?" So the kids sort of understand and it's really nice to as a nice way to sort of involve them in the study a little bit more. Some of the initial work we've done, we've sent a second round of our ALL cases to Manisha's lab to do. But you can see as an example here from 3 of the metals that we analyzed in the first cases that we sent, do seem to be some important patterns with some of these. And I think the really cool thing about this, again, the vertical gray line in each of these represents birth and the way the tooth forms. And again, this varies from tooth to tooth because the teeth start developing at different time points. But you've got up to 20 weeks prior to birth, and then he's measuring 40 to 50 weeks after birth from each of the teeth. And you can see some really cool differences between cases and controls here. So, for example, in the magnesium graph on the left, you've got lower levels in cases compared to controls prior to birth, but you've got mostly higher levels in cases compared to controls after birth. And so I think we're really starting to see some interesting patterns in some of these data that we can hopefully use to start looking at these really early life exposures and how they may increase risk for development of childhood cancer. Um, the other way we can overcome some of these measurements, especially looking at what happens prior to birth for a lot of these kids, is newborn screening. And for those of you in California or Michigan, New York even, where you're still storing dry blood spots and they're able to be used for research, these are not untapped, I would say an underutilized, because many of us are using these for different studies, but they're an underutilized resource. And we can now do a lot of different analyses on these particular samples. And they're collected again from every child that's born. Now, they may not be technically stored for that, but each of the punches or each of the spots can have several 5 millimeter punches made of the spots that can be used for measurement of endogenous metabolites, exogenous chemicals, and again, like I mentioned before, it provides a really good snapshot of what's circulating at the time of birth. And we've worked with Dr. Lauren Petrick, also at Mount Sinai, whose lab is focused on perfecting, the use of or the analysis of metabolites and some of these other exogenous chemicals from the dry blood spots. Now, another one of the opportunities that I said we had is to identify vulnerable populations, because if we can figure out the commonalities that may exist between several different geographic vulnerable populations, we might be able to come up with some ways to start dealing with these exposures. So one of the things that we've done, we try to use registry data as much as possible. And Dr. Tan Hong, Dr. Abby Olyomi, some of my colleagues who are still at Baylor College of Medicine, used the data on pediatric brain tumors that were reported to the Texas Cancer Registry that were diagnosed between the years 2000 and 2017, and used a spatial clustering analysis in the SAT scan algorithm. And they identified 20 clusters. And four of the clusters, the ones that I'm showing you highlighted on the map on the left, were all around oil and gas industry components. So we had, cluster two just above the Dallas-Fort Worth area, where we had 451 census tracts that were involved, with a relative risk of 1.3 in terms of the number of expected versus observed number of cases. Cluster three was just outside the Houston area. Again, really high relative risks there, but involved a smaller geographic area, only 3 census tracts. And then there was another cluster around the Houston area as well, 16 census tracts included there. And this ended up, when we did the mapping, put us out in the Port of Houston and the Houston Ship Channel, which, for those of you who know, many reports of excessive cancers in that area. Ton also took those data and started to look at the proximity to oil and gas wells and mortality in children who were diagnosed with cancer. So the map on the left side shows the active oil or gas well components that were active in the state of Texas. And they represent different kinds of components. For those of you who may be familiar with oil and gas discovery and extraction, they're listed there. And she used, again, the Texas Cancer Registry data and looked across 25 different pediatric cancers, this time using data from 1995 to 2017. And the exposure was based on address at diagnosis with the cancer. And she looked at a geographic area of those individuals who lived within 500 meters, 1,000 meters, or 2,000 meters of each of these wells or components. And for a number of different cancers, she actually saw increased risk of particularly AML, hepatoblastoma, anaplastic astrocytomas, and glioblastomas. And again, you see the wide confidence intervals here relevant to some of these more infrequent pediatric tumors. But I think the message is overall that these exposures are likely associated with some, but not all, pediatric cancers. And for some of these cancers, like with the AML data here, you see a decreasing risk the further you live away from some of these. But for things like glioblastoma, we see a pretty consistent risk estimate, regardless on how far away from the exposure you live. So 500, 1,000, or 2,000 meters didn't really matter. We're still looking at an effect estimate, somewhere around 1.8 or 2. All right. Another area of interest, and this has been really in collaboration with my colleagues in Minnesota, but can we overcome the effects of environmental exposures? And one way that we can look at this is greenness. So we know that having vegetation, especially trees, in your area can help remove a certain percentage of, especially the particulate matter that might be polluting the air in your area. So we wondered, okay, there have been some associations between, especially PM 2.5 and pediatric cancer risk, but what happens if you account for the amount of vegetation or greenness in those areas as well? So, Dr. Lindsay Williams, who was an assistant professor in the Department of Pediatrics at the University of Minnesota at that time, and Dr. David Haynes in the Institute for Health Informatics, really led the charge on doing these analyses. We used, again, data from the Texas Cancer Registry across 26 different pediatric cancer diagnoses. The data we had available for us for this particular analysis were between 1995 and 2011, and that included information on slightly more than 6,000 pediatric cancer cases. And we had data on just under 110,000 controls from the Texas Vital Statistics Registries matched to our cases on birth year and sex. So again, since we were doing a case control analysis in this regard, we used address at birth to calculate annualized averages for each of those years of birth. Sorry about that. For both the greenness, so the NDVI or the normalized difference vegetation index, as well as PM 2.5 measures. And both of those measures came from satellite imagery data that Dr. Haynes has been analyzing for a number of different outcomes. We also adjusted for a measure of SES using the Yoast index in these analyses. So this map shows you some changes in the PM 2.5 averages over time. So top left here is in 2000. Next to that, to the right, is 2005, and then 2010. So one thing I want to point out is that we've done a better job of limiting some of these particulate matter exposures over time, which is great. But you can see that there are still areas as in the state of Texas where we have higher than we'd like to see estimates of some of these exposures. At the same time, the greenness data showed that, I think overall, over the same time frames, we have seen some erosion of the tree canopy and the vegetation index over time, but not as much as one might expect. So we're hanging on to our greenness and doing a better job of reducing some of the air pollution measurements, which is great. Those are the two primary messages I got from these graphs when I first saw them. So what Lindsay did with the data is she looked at the odds of cancer development for each interquartile range increase. And as you can see here, this first set of graphs shows you the increase of cancer risk based on the greenness. And this is adjusting for the PM 2.5 measurements. So let's orient ourselves. The red bars indicate significant increased risk. So neuroblastoma, there was an 11% increase. For malignant melanomas, there was a 0.7 or 75% increase. And for Langerhans cell histiocytosis, there was a 56% increase. Now, this might be a little counterintuitive, and I don't really know how to explain the neuroblastoma. But I think the malignant melanoma and to some extent the LCH, which has a little bit of a UV component to it as well, could be the increase with the increase in vegetation is that in areas with higher vegetation, the environment is more conducive to people being outdoors. So you have more people spending more time outdoors. Now, on the other side, on the protective side, so ependymomas and medulloblastomas, we see significant decreases in cancer risk associated with increasing NDVI. And for these two in particular, the ependymomas especially, we and others have reported that higher levels of air pollution in general are associated with increases in risk, especially of ependymomas, but we've seen it with medulloblastomas in some studies as well. So it could be that the increase in vegetation is doing what we expect it to do, which is removing some of these PM 2.5s from the environment. and is contributing to the reduction here. And likewise, if we look at the increase in, or the associations with increase in PM2.5s, adjusting for the greenness index, we see an overall increases for ALL, Hodgkin lymphoma, non-Hodgkin lymphoma, ependymomas, retinoblastoma, and thyroid carcinomas. So again, some interesting results by looking at both the effects of the air pollution after adjusting for the greenness levels. Some more work coming out of this, but early indications that we're able to look at both of these in conjunction together. So the next slides I have, I want to talk a little bit more about why I'm so interested in trying to understand the association between environmental exposures and outcomes. So a lot of the work we've been able to do in this area so far has been in leukemia. So most of what you'll see from me today in this regard is related to leukemia. But we formed the Reducing Disparities in Acute Leukemias Consortium across several sites in the U.S. And there are a few things from the initial data that we have available here. One, we've looked a lot at our Latino patients, but Latino patients in particular seem to fail upfront therapy, so that induction phase of leukemia therapy, or they die during induction more often than non-Latino patients. While it's still a rare outcome, the fact that twice as many, or percentage-wise, twice as many of our Latino patients are failing upfront induction therapy is alarming, and what could be contributing to that. Secondarily, we also know that both non-Latino Black and Latino children have the highest rates of relapse for their leukemia compared to other groups. Again, what are the reasons behind that? What factors could be driving those outcomes? One of the clinical indicators that we have to be able to predict risk of relapse is minimum residual disease that occurs, or that it's measured at the end of that induction or initial phase of therapy. And we know that individuals who are MRD positive, or who have more residual disease than they should at the end of induction, are at increased risk for relapse compared to those who are MRD negative. But you can still see that individuals who are MRD negative still have some level of relapse happening for them as well. And if we look in that MRD negative group, which should be the ones who have better chance of not relapsing, the individuals who have the most relapses but are MRD negative are our non-Latino Black and our Latino patients. So why is that? Again, these kids should have better outcomes, but they have worse ones compared to everyone else, and we don't fully understand why. So we've been trying to look at some of these factors available from some of the data we have, and the forest plot on the left side shows the risk of relapse by MRD status. So the blue boxes are the ones that are MRD negative and should have better outcomes in relation to relapse. But our, again, Latino and Black patients, after adjusting for patient level factors, so the normal sort of clinical risk factors that we know about, are still about 61% more likely to relapse compared to non-Latino white patients after adjusting for those among those who are MRD negative. Now, we took it a step further and we additionally adjusted for neighborhood level factors, so socio-deprivation index, other measures of environmental exposures that we can measure at the neighborhood level. And we can see that, especially among Latino patients, that further exasperated the disparity that we see for Latino patients, whereby they are now 2 times more likely to relapse, being MRD negative compared to non-Latino whites. So there's something else in the environment that seems to be driving this disparity, especially among Latino children. Now, I mentioned before, one way to really get a look at some of this is, what's going on in the body at the time of diagnosis. And can we use some metabolomic analyses to help predict who should or shouldn't be MRD negative? So we took diagnostic bone marrow samples and we analyzed the plasma that was separated from those diagnostic bone marrow samples and did unsupervised metabolomics. And you can see that there are a number of metabolites in those bone marrow samples that will differentiate the individuals who end up being MRD positive from those who are MRD negative. And if we look at the predictive ability of this, the red line indicates the predictive ability of just using clinical variables, so risk group and some of the other, initial white blood cell count and so forth. Some of the initial clinical factors associated with that we know are associated with MRD positivity and relapse. And if we add these metabolomics data on top of that, we greatly enhance our ability to predict those who will be MRD positive at the end of induction. Now, there's still some work to be done, right? We only go from an AUC of about 64% to 73%. So there's still some work to be done, but we're heading in the right direction by using some of these omics data. And again, we know that where you live matters. I'm preaching to the choir with the folks who are on this particular webinar. But we're starting to look at not only measures of socioeconomic status, but also measures of enclave. So living in areas where you're more like people who are like you rather than living in areas where there's more diversity. And for this particular analysis, we saw that individuals who lived in Latino enclaves were more likely to be MRD positive at the end of induction rather than those individuals who lived in non-enclave areas. So what's going on there? Not really sure, but it's giving us a hint that again, where you live really matters, and it's not just about access to care. It's not just about socioeconomic status. There's something else that's contributing to some of these outcomes that we're interested in. Okay, so last few slides. Where do we go from here? And this is sort of a model that we've put together to try to guide some of our next steps. But again, if we look along the trajectory from diagnosis through treatment and into survivorship, we know that there are environmental exposures that increase oxidative stress, that provide for the development of epigenetic alterations, that have chronic inflammatory responses due to these exposures and can lead to hormonal dysregulation. And we've seen a lot of work that associates these particular measurements with the diagnosis or the risk of developing a cancer. But how do they maybe also influence some of these other outcomes that we're interested in? Toxicities during chemotherapy or radiation therapy, the risk for relapse, the risk for chronic health conditions among survivors, the risk for second neoplasms among survivors, and earlier than anticipated death among individuals who survive their cancer. And there are a number of environmental and climate-related stressors that can all have both direct and indirect effects along this sort of treatment and survival continuum, but we don't yet fully understand how we might be able to evaluate these. So those are important points that we're trying to incorporate more into what we're doing. And this is just kind of a model here, right? So we've got several environmental stressors that we know we have several different exposure timings that could be happening that could be leading to any of these outcomes that we're interested in. And while there are neighborhood level vulnerabilities, so how much air conditioning individuals have in their neighborhoods, how much green space is there, are there other climate vulnerabilities or social vulnerabilities? Are there food deserts? Are they getting enough nutrition? Is there residential segregation that's contributing to some of these? There are also individual level factors that we have to consider. Being born preterm, being born low birth weight, being born in a low SES or low socioeconomic position areas and poverty. There are also biological and genetic differences. So we've got some data that suggests that the biology behind the leukemia that develop in Latino children and African American children may be different. And why is that? We don't fully understand that. It could be differences in exposures, but it also could just be differences in their immune biology. We know that immunobiology across different racial ethnic groups and ancestral groups is very different for a number of evolutionary reasons. But we also have to think about the mediators or moderators that also might be contributing to some of these things between environmental exposures and outcomes, such as, again, being born preterm or low birth weight. But the level of obesity, the epigenetics that individuals have or maybe don't have related to exposures or stressors that happen in their lives or their parents or grandparents' lives. And then the ability of measuring these through metabolomics and other omics are continuing to develop. So, just a few closing thoughts. Variability in cancer treatment outcomes, which is something I'm very interested in right now, definitely exists, and we do see a lot of disparities for Latino and non-Latino Black children. Treatment-related toxicities are also of a special clinical concern, and they, at least from some of the data that we've shown, disproportionately affect Latino and Black children. But the extent to which the environment might contribute to some of these outcomes is really not fully understood. And I think that's where we need to be moving as a field. And we need to think about the global assessment of the full spectrum of these factors that could be related to these outcomes. So not just looking at the environment, not just looking at, socioeconomics, not just looking at genetics. I think we have to really start being able to look at all of these component causes together to really get at these disparities and overcome them. So these are just a list of the few people who've been involved with some of the data generation that I showed today. And with that, I'll end, and I'm very happy to have a discussion with you all. And I'm happy also for anyone to email me in the future to have other conversations.
Thank you so much for that. That was excellent. Like such a great overview. And that slide that you had of kind of the diagram of everything, I think was just so one of the most comprehensive ways to explain it. And it almost like puts in perspective that really the environment where we live, where we eat, where we sleep is just part of our social, it's a social determinant of health. Like clinicians
Yep.
really, I think, put the environment in that category, and that was an amazingly comprehensive way to show that. And I think that's really helpful to put in that perspective. So thank you so much for your wonderful talk.
Of course.
We have a few questions in the chat, and I'm not sure if people can unmute, but I can just share them. So Dr. Wolf asked, when you're talking about leukemia and some of like the studies you were doing, um, are you looking at ALL alone, or is it kind of leukemia in general that you used?
Yeah, so it really depended on the slide. And I tried to be as specific as possible when I talked about it. In general, obviously, if I say leukemia, it's the broader group of leukemia. Most of the work we've been doing has been in the ALL space, again, just because it's more common. But we do recognize that there are some specific exposures, especially from the environmental side, that may be a little bit more targeted toward AML. So we're trying to amass enough AML cases with the needed data so that we can really start looking at AML as well.
Yeah, I just wondered whether when you talked about the disparities between Latino communities and Black communities, you were talking about leukemia
Yep.
and whether or not that was all comers or just ALL.
Yeah, so in that regard, it's really all comers. I mean, obviously, the biggest disparity for Latino patients is on the ALL side of the equation. I think there's some really interesting things in the African American population. We, at least from the data we've looked at, we tend to see more TALL than BALL. We've also noticed that there tends to be more AML in those patients compared to some others, but it's very preliminary, and again, the numbers of AMLs we have to be able to look at some of these other factors is limited.
Thanks.
Yeah,
And then we have a anonymous attendee who asked, do you think that mold in the home is a factor for pediatric cancer? And I guess getting more at even general, like in-home exposures.
Yeah, that's a really interesting and great question. We've thought about this a little bit over time. We haven't looked at it specifically much because it's kind of hard to get a good measurement of that. But I will say, there again, we have opportunities, I think, to look at some vulnerable populations, and this kind of sparked an idea. We didn't look at this, we should have, but where you have these large climate events that happen. So I'm thinking particularly of, I was in Houston for 20 whatever years while I was there. We had several hurricanes, and a couple of them came with significant amounts of damage, and a lot of people had mold growing in their homes after, Hurricane Harvey and some of the tropical storms that we've had. So, we could try to tease apart some of that information a little bit. I do know that I've had some colleagues who very interestingly look at mold in relation to, asthma development and some of the other respiratory disorders that children have, and they have seen things there. So it's not implausible in my mind that, mold exposure can lead to some of the other things that may be important for pediatric cancer as well.
And then we have another it looks like, can you unmute yourself? Isat? Sorry if I pronounced your name wrong. Are um Arzika? Are you able to unmute yourself? I can also ask your question. Okay, I'll ask. And then kind of similarly, are there specific exposures in the home, schools, communities that parents should really prioritize reducing? And I think that gets sort of at the prevention aspect of this.
Yeah, that also a great question. And oh,
Yes.
yeah, great. So let me try to answer. I don't know if I have a great answer for you. I think a lot of the work that the PEHSU network has been doing really points at some opportunities that we have. I think a lot of that research that I've seen focuses more on air pollution exposure. So what can you do to limit, your exposure to different forms of air pollution? And there are some specific ways that you can go about doing that. Obviously we've known for a long time limit exposure to lead in the home and other things. So people have done that. So I don't have a great answer for you, but I think, limiting some of the exposures that we know are not good for your health in general should also be some of the things that we focus on suggesting to people for, cancer prevention methods. And we're also trying to, a group of us on this call and others, really focus a lot more on cancer prevention, especially in relation to environmental exposures and how can we make some of those suggestions.
All right. Okay. Thank you.
Yeah.
And PEHSU has a lot of resources on their website, just like Michael was saying, of kind of general good environmental health and healthy homes aspects. And so that's definitely available. I think, Marissa, do you want to unmute and ask your question?
Sure. Hi, Michael. Marissa Hauptman from Boston Children's. I'm one of the co-directors for our center here. Work closely with Alan. Um, and we have a similar, like a 10-year data set in collaboration with Dana-Farber, looking at
Mhm.
different patterns of neighborhood context and its relationship with morbidity and mortality. And was wondering, sort of in this current climate and landscape, how sort of the federal administration has impacted sort of your funding that you currently receive and any um, guidance as you think about future grant opportunities and whether there's opportunities
Yeah.
to expand your cohort to include Boston.
Yeah. So I think, and I wrote your name down, Marissa. I'm going to follow up with you because I think there's some
Sounds good.
opportunities here. And we have some other colleagues at Boston Children's and Dana-Farber that I think we could, kind of loop into some conversations. But yeah, right now, in particular, it's hard to get funding for the environmental, aspects of what we're doing. What we've tried to do is, and what we've continued to do, and we've done this all along, is when we're talking about disparities, we try to couch the disparities in relation to um, these allow us to pinpoint some exposures maybe that we're interested in looking at to explain the disparities, but they're applicable across the board, right? So we're really trying to understand the impacts of environment or these other factors on cancer and health in general, and any information that we can glean from these vulnerable populations really provide us information that's helpful for everyone. So it's a little bit more about just kind of reframing the way you're going about the question rather than changing the questions that you're actually wanting to do. I know that's probably not very helpful, but that's the
No,
tack that we
it's just
take.
helpful to hear your lived
Yeah.
experience. So that's great.
Yeah.
I think we have time for one more question. So I'll let Omar ask his question. Hi, Omar.
Hey everyone. Sorry, there's an echo in this room. Michael, thanks a lot for your great presentation. As you know, this is something I've been very interested in, and I appreciate you working with us here at Texas Children's on this important topic. One thing that really stands out to me is how interested the families are in this conversation, and being talking with them as their oncologist is something that they've really voiced that this is something they want more information on. How do you recommend we reach out to other pediatric oncologists to help? We know that they don't have as much understanding or awareness of this topic. So, what are some strategies we can use to help educate our patients?
Yeah, that's great. And Omar, I think, you guys are doing this already. So, this concept of a environmental referral service, I think is an excellent one. And you and Mark and others have really sort of picked the battalion up and trying to run with that. And I think there are a couple of approaches here. One, and you know this as well, our oncologists are just overrun, right? There's too much for them to do. There's, constant pulls on their time to make sure that they're getting the clinical things done that need to happen. And, a lot of them don't feel comfortable with addressing family questions about these exposures. So I think as much as we can do to put together information for families, have a place for them to go. That's why I think things that PEHSU are doing is so important because it provides a resource for everyone, families, providers, everyone to really think about, what we can do. And I know for, in conversations we've had jointly and otherwise with parents, especially, they're not just concerned about like why did this happen to my kid? It's, is this gonna happen to my other kids if they have any, or if I want to have any more kids, is this gonna have, provide other problems for them? So it's a huge issue that a lot of people I think are a little bit more cognizant of and thinking about. It's not just the, oh, it's bad luck kind of thing, but I think parents are a little bit more cognizant of everything and really asking the questions that unfortunately a lot of our providers aren't trained in how to answer. So I think it's providing education to the public. I think it's providing education to our providers. I think it's providing opportunities for providers to pass the baton on to other individuals who have the training and know how to answer these questions, know how to, convey risk. Talking about risk to the lay public is really difficult, and it's hard to talk about absolute risk versus personal risk versus, relative risks. And so I think a lot of people just don't have the exposure to learning how to do those things. So
I'm sorry we didn't get to all the questions. We might need to have you come back.
I know.
Thank you again so much for all of your wonderful work and for kind of pushing this really important field forward. I just wanted to quickly highlight a few things from the CSEP program webinar series. So our next one will be in February. We haven't quite solidified the date yet, but please come back and join us for that. Dr. Ortega Garcia, clinician from Murcia, Spain, will be presenting with his colleagues on their clinical environmental pediatric cancer survivorship program, where they really meld clinical environmental medicine into their pediatric cancer survivorship cohort, as well as some of their research in environmental medicine. So look out for that. And then I also wanted to highlight that our group is kind of hot off the press with a bunch of articles related to pediatric cancer and the environment. So it was a special issue in the current problems in pediatric cancer and adolescent medicine. So please feel free to read all of that. When we send out our post webinar, we will include this link. And then, of course, if you would like, please subscribe to our newsletter so you can keep up to date on all the things that PEHSU CSEP program is doing. And then this also will be sent out at the later survey. I thought I could put it in the chat, but it doesn't look like there's a chat. So please, if you can, take our survey. It really does help us kind of better put better lineup speakers to meet everybody's needs in this dynamic call. And I've really just so much enjoyed all of our speakers here recently, as well as the conversations after, and how passionate really everybody is about this topic. So please feel free to leave us feedback, and we're happy to incorporate it, and we'd be more than happy. So thank you again, everybody. I think we're just at 4 o'clock, which is great to give everybody their time. I hope everybody has a safe and happy holiday season. And thank you so much again, Michael. It sounds like you already have some collaborations in process, and this is a
Perfect.
great conversation.
Yeah. No, thank you, Hannah, again. I really appreciate it. And it's been a pleasure being with you all today. So thanks so much.
Thanks. Bye.